Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Sanjay Bindra. Dr. Sanjay Bindra is board certified in cardiovascular medicine, cardiac electrophysiology, and internal medicine. Dr. Bindra attended medical school at University of Bombay, India. He completed his residency at Los Angeles County and the University of Southern California. Dr. Bindra completed his fellowship at St. Luke's Medical Center and Aurora Sinai in Milwaukee, Wisconsin, as well as Los Angeles County and the University of Southern California. Dr. Bindra currently practices medicine in the field of cardiology.
So I'll talk today about diabetes and heart disease, but this will also cover a little bit about pre-diabetes because heart disease starts even before you get diabetes. So how dangerous is diabetes? It kills close to about 60,000 of us every year, and many die from the complications from it. It is the leading cause of blindness, the leading cause of non-traumatic amputation, leading cause of kidney failure requiring dialysis. It increases the risk of stroke, of heart attacks, peripheral arterial disease, and actually 3 in 4 individuals with diabetes die because of heart disease. So that is why endocrine and cardiology is connected. So what is the lifetime risk for diabetes in someone born in the year 2000? So 1 in 3 of us are going to develop diabetes during their lifetime. This risk is a little higher in minority subgroups like Hispanics, American Indians, South Asians, African Americans, Pacific Islanders, and this continues to increase. So in the 1990s, majority of the country is in light colors. Darker color means that higher percentage of diabetes. So the darkest color means that more than 10% of the population is diabetic. So in the 1990s, we were healthy as far as diabetes is concerned, with majority of the country less than 6%. In 95, the southern states, Texas, New Mexico, and Arizona, close to us, are getting into the 8% range. And see what happens in 2001. The Florida and some of the southern states, over 10%. California is close to 10%. And this continues to escalate. So as diabetes increases, so does heart disease, and so does the risk of death from heart disease. Now what really is diabetes? How do you define diabetes? Diabetes is defined by your blood sugar levels. Yeah. So there is something called a fasting blood sugar and something called a postprandial or post-lunch blood sugar. So by definition, if the fasting blood sugar is more than a number, 126 was what it is now at, or if your blood sugar is more than 99, then we call it pre-diabetes. So in other words, you are healthy and you're diabetic, and in between you're pre-diabetic. And the reason pre-diabetes is important is because although you've not reached diabetes yet, you've already developed heart disease by the time you develop diabetes, because in pre-diabetes, blockages already develop in the vessels. So we will go over that during this presentation. So what are really the symptoms of diabetes? Most individuals are actually asymptomatic. They have no symptoms. It's only when the blood sugars start to go above 180, when they start peeing a lot. Someone called it as the diarrhea of the urine. Means that if you have polyuria, if you pee a lot, if you feel thirsty, you lose weight. These are the common symptoms, and some infections which start developing. So anyone who has untoward symptoms should get their blood sugar checked, and irrespective, anyone above the age of 45 should have their blood sugar checked, because this could be totally asymptomatic and only discovered during a blood test. Remember that by the time you've developed diabetes, you've already developed some form of heart disease. So what is the relationship between diabetes and heart disease? Diabetes is because insulin, which is one of the key hormones which is produced by one of the organ in our body called the pancreas. Pancreas secretes insulin so that the cells are able to take up glucose, which is a sugar. So when we eat, the body needs energy, and glucose is a form of energy, and insulin is actually the key which essentially opens the cells so that they can take in glucose. So if there is less amount of insulin secreted, or if that insulin is unable to act well, a person has relative deficiency of insulin, and the blood sugars start to rise in the blood because they can't be taken into the cells anymore, and the person is diabetic. So what we call insulin resistance is that a person has insulin, is secreting insulin, but however that insulin is not really functional because the cells are resistant to it. That is the key concept of insulin resistance. Most patients that we see in clinical practice have this insulin resistance type of diabetes, what we call type 2 diabetes. 95% of all individuals with diabetes have type 2 diabetes. Type 1 diabetes, which occurs usually in the younger subjects, that it is because of destruction of the pancreatic cells, usually by autoimmune, called type 1 diabetes, and these patients are insulin dependent. But for the most part, what patients we see in practice are usually type 2. So there is an interrelation between atherosclerosis. Atherosclerosis means deposition of fat in the vessels, and insulin resistance. And the reason for that is, it's not that someone is just diabetic. Things like high blood pressure, abnormal cholesterol, they're all linked with it. So often when you have diabetes, there's an interplay of what we call metabolic syndrome, and an individual is often obese, and that's the reason an individual has insulin resistant and is diabetic, has hypertension because of that, has abnormal cholesterol profile because of that, and it is in multiple risk factors that have already developed when an individual is diabetic and forms fat in the arteries. So this shows the risk factors: hypertension, high blood pressure, defined as a blood pressure more than 140/85, diabetes, defined as a blood sugar of more than 126, high cholesterol, both high bad cholesterol, which is the LDL, depending on your risk factors, and of course one of the ones which is easily modifiable is smoking. So these are the risk factors which essentially lead to atherosclerosis, and diabetes essentially affects, because of atherosclerosis, affects the entire body, because the blood vessels are affected and each and every part of our body requires blood, and the blood vessels go and feed each and every organ, so that when an individual develops complications, we physicians divide them into two types. One, what we call macrovascular complications. What that means is large or medium sized blood vessels, like arteries which supply blood to the brain, to the heart, to the legs. These are big vessels, and these get affected actually even before you have diabetes. When you have impaired glucose tolerance, you already are starting to develop blockages in these vessels. Versus these microvascular complications, which affect the small vessels, the capillaries, like the eyes, the retina, the kidney for nephropathy, or the nerves with peripheral neuropathy, wherein somebody develops tingling, numbness and pain in the extremity. These develop because of diabetes later, so that if an individual is diabetic and is treated early, you can actually delay a lot of these microvascular complications. The macrovascular complications, meaning stroke, heart attack and peripheral arterial disease, for which that's the leading cause of non-traumatic amputations, they've already developed by the time you've become diabetic. So treating diabetes helps, but it would have been a lot better if it could have been diagnosed in the pre-diabetic stage, and changes would have been brought about to even prevent all of this. And so we'll be talking a little bit about that. So someone says, you know what, don't worry, I only have a touch of sugar. But that ain't good, because by the time you have a touch of sugar, it's already too late, because you've already developed diabetes and you've already developed vascular disease. So our job at physicians at that point is slow the progression, because you've already developed vascular disease. It would be a lot better if you could have met a lot of these subjects way early, or lifestyle modification was carried out even before someone's blood sugars were abnormal. So here you see why it's a silent killer. This term was used more for blood pressure, but it also applies for diabetes too. So essentially we went over this a little bit, is that diabetes, the type 2 type, occurs primarily because insulin is unable to act. So this is part of it is the effect of the genes, and part of it is environment primarily the diet. So as we become obese, we have abdominal adiposity. It increases resistance to the action of insulin, and there is relative deficiency of this key hormone. Blood sugar increases and we develop diabetes. Versus someone who is healthy, the body adapts to the needs and the blood sugars are always normal. But when body is unable to meet the needs despite secreting insulin, which is relatively deficient, and individuals' blood sugars go up. So this is the real cause of diabetes. It's the urbanization which has occurred. The diets have changed. People have become less sedentary. We are eating and drinking a lot of refined sugars. We are all growing in size, and hence the prevalence is increasing. In the next 2 decades, majority of the diabetics are going to be seen in Asia. In India, 1 in 5 diabetics in the world is going to be from India. Significant number of diabetics are going to be in Southeast Asia, and China is going to double the number of diabetics within a 30-year period. So formerly it was a disease in the developed world, and you can see with urbanization what is happening. People are eating richer diets or exercising less, and the environment is playing on these individuals with susceptible genes, and diabetes is an epidemic now worldwide. Diabetes doubles the risk of heart attacks, and this is despite advances in cardiac care. So if you have an individual who comes with a heart attack, and there's another individual who's diabetic and who comes with a heart attack, his mortality is twice that. So much so that diabetes is considered a coronary artery disease equivalent. What does that mean? a diabetic who comes into the office, and there's another patient who's a non-diabetic who had a heart attack and who comes to the office, their mortality is similar. So in other words, by the time someone develops diabetes, they've already developed vascular disease, and then we start treating individuals aggressively with goals equal to someone who's already suffered a heart attack. Women are protected from heart disease till they reach menopause. That protection goes away the moment they become diabetic. So moment a woman is diabetic, the premenopausal protection is lost, and their risk of heart disease is equal to a male. And actually diabetic women actually have worse complications than diabetic men. So all of this takes place because each and every part of our body needs blood, and blood is taken by blood vessels, and blood vessels have a wall. So here there is a depiction of what we call an endothelial cell. This is a cell which is in the wall of the artery, and this is the blood which is circulating in the tube. And the oxidized bad cholesterol essentially makes its way under this lining, and essentially the macrophages, which are the cells, the monocyte from the blood which goes in and forms the macrophage and engulfs this bad cholesterol and essentially keeps growing and forms the foam cell, and subsequently more deposition occurs, and you start developing a bigger and bigger plaque in the artery till the artery gets occluded, or this plaque essentially ruptures and a clot forms, and suddenly the vessel which was about 30% blocked becomes 100% blocked, and the organ which it is supplying, if it's the heart, heart suffers a heart attack. If it's the brain suffers a stroke, and if it's the leg doesn't get any blood supply, and the person has pain in the legs and is unable to walk, and there's no pulse, the color changes, and one of the causes of amputation. So essentially this process takes decades to develop, and by the time a person is diabetic, this is well established. So when patients come to us, they often come to us with symptoms. Here this is a male holding on to his chest because he's complaining of chest tightness. This is occurring on a cold winter night as he's walking uphill, and this is a pressure which he's experiencing in his chest, which is going down his left arm. Unfortunately, diabetics don't always present with this classic syndrome. Diabetes, as we know, affects the nerves too. So sometimes you have what we call silent heart attacks. The patient comes to the office, we do an EKG, and we say, oh, by the way, you know, you've suffered a heart attack at some point in your life, we don't know when, and the person didn't know about it. And often individuals come with atypical symptoms. Sometimes they may just be sweating profusely, sometimes present with epigastric discomfort in the lower part of your chest and upper part of the abdomen, and sometimes just with severe shortness of breath. So what we call atypical symptoms. So an individual could present with typical chest tightness, feeling like a pressure on the chest, going down the arm or going up to the jaw, lasting for minutes together, or could on the other hand just be totally asymptomatic. So how is heart disease, CAD, different in diabetics? Number one, the individuals are younger when they have diabetes. They'll develop heart disease younger. It doesn't spare women. And there is something called silent heart attacks. The disease, if it occurs, is often more severe. It affects the vessels even distally, so it becomes a little bit difficult to open those vessels up. And a lot of them may have multiple blockages, may require multiple stents or bypass surgery. And not just that, even after treatment, these individuals do worse because the stents are more likely going to close, the bypasses are more likely going to get clogged up if their diabetes is not treated. So it's now we understand why it is a deadly disease. Remember that 70% of all death in diabetics is because of heart disease. But we know that improved blood sugar control decreases your risk, especially of microvascular complications. Remember, we divided the complications into two types: the macrovascular, which are the big vessels, stroke, heart attacks, and peripheral arterial disease, or the microvascular. The microvascular, the retinopathy, which causes blindness, the nephropathy, which causes kidney failure, or the neuropathy, which gives numbness, that is much improved or delayed if we control diabetes well. The macrovascular complications are reduced a bit, but here its intervention is late. It would have been a lot better if we could have met these individuals before. But nevertheless, improving all the other risk factors, like if someone is smoking, to quit smoking, control blood pressure, control their diabetes to the goal, control their cholesterol, bring down their bad cholesterol, increase the good cholesterol with diet and exercise is very important if we want to reduce the risk of complications. So how do we really diagnose heart disease in someone who's got diabetes? If a person comes to the office, and EKG gives a good representation of what is happening at baseline. It may tell the physician if the person has suffered from a prior heart attack or not. But often we have to resort to what we call stress tests, in which we exercise the individual either on a treadmill, or we give chemicals which raise the heart, or we give chemicals which redistribute blood, and then we either do what we call an ultrasound, an echocardiogram, or a nuclear study to assess whether the blood flow to all areas of the heart is equal during times of increased need, or if the patient's symptoms are related to decreased blood supply. And more invasive procedures include an angiogram. These days an angiogram can also be performed with a CT scan. But if patients already have symptoms and have abnormal stress tests, then one proceeds to an invasive angiogram, which is done at the hospital in a cath lab. If someone comes in with chest discomfort to the emergency room, often the doctors will keep you in for observation to see whether you're having a heart attack or not, and that is by checking this blood chemical which is called troponin, because troponin is a heart muscle protein, and if the heart muscle is damaged, the troponin is secreted and the blood levels can go up. So they often will keep you in the hospital for up to a day to see if your troponin value increases, and if it does, that's how we describe or confirm that an individual has suffered from a heart attack. So this is an ultrasound of the heart, and we can do a stress test to see if all the areas of the heart all the areas of the heart move well. This is a nuclear camera. This is a nuclear study. The individual comes from home, gets a resting study. They're under a camera, and then a stress test is performed, either exercise or with chemical, and a repeat test is performed, and we compare the rest images with the stress and see if all areas of the heart are receiving equal blood supply, or if it's unequal, and which areas are not receiving, and accordingly it helps when we go to the next step, which is an angiogram. This is a depiction of what a CT angiogram looks like. Here the individual has gone under a fast CT scanner, or these days 64 slice and 128 slice, and they are able to reconstruct the image of the heart. So this is the right upper chamber, the right lower chamber, and this is one of the arteries. This is the coronary artery. This is the right coronary artery, and this is the left coronary artery. And then one is able to slice images and look at inside the artery whether there are any blockages or not. So the right artery and the left artery. So that can help diagnose non-invasively. And this is an invasive angiogram, where the individual is in the hospital, wherein the physician has taken up catheters either up through the arm or through the leg, and the catheter is sitting in one of the arteries which supplies blood to the heart. Radio opaque contrast is injected, a dye is injected, and you can outline this vessel. This one is a nice, smooth, normal vessel. And if an individual has blockage, then you will see that, and the treatment is dictated by what the findings are. So now we talked a little bit about how big a problem diabetes is, why it is important. We've already talked about what type of complications ones get, and then how does one really manage diabetes. The key thing is diet and exercise. So increasing the exercise to at least 30 minutes a day, if not longer, up to 150 minutes a week, if not more, is going to assist, and especially reducing the caloric intake, reducing the amount of saturated fat, decreasing the amount of carbohydrates, especially the easily absorbed types, sugars, using more complex carbohydrates, increasing protein. All of this is going to help, and of course quitting smoking if someone is still smoking. And medications will assist to reduce complications or delay complications, and of course procedures can help take care of symptoms of the patients, and in some cases when they have advanced disease, help them live longer and better lives. So this slide shows it all. If it would be nice if the office is up here and individuals have to take 1,000 steps to go up, yeah? So that itself will be enough exercise. If you can make it up here, then you probably don't need to go up there, huh? So this is the Heart Research Center. So once you have diabetes and you have heart disease, aspirin has been shown to improve survival because of reduction in heart attacks. So if someone is developing sudden chest discomfort, so the first thing that someone should do is take a bare aspirin, 325 milligrams, and chew and eat it. That is the best the best form of treatment that you can take at home while the paramedics are bringing you to the hospital. So aspirin is very important, and aspirin has been shown to improve survival in patients with diabetes and coronary disease. And the HOPE study has shown that ACE inhibitors, these are medicines the doctors prescribe, a specific type called the ACE inhibitor, they've been shown to improve survival in individuals with diabetes, reduce heart attacks, reduce strokes, reduce kidney problems, and these are very effective medicines. So these are often prescribed early in the course to prevent complications. Beta blockers, these are the other medicines like metoprolol, which the doctor prescribes. They've also been shown to improve survival in patients who have diabetes. Blood pressure needs to be controlled, but there is always a debate whether it needs to be less than 120 or less than 140. In other words, should we be very aggressive or should we just control it less than 140? The studies have shown that keeping a blood pressure less than 140 is good. Trying to be too aggressive is not necessarily better than keeping the blood pressure less than 140. Yeah? The blockages which develop can be reversed too by these medications, and especially statins. And studies have shown that aggressive lipid lowering with medications called statins can actually reduce plaque. Here, Dr. Nissen from Cleveland Clinic has essentially gone in with cameras into the arteries which supply blood to the heart, called the coronary arteries, and done serial studies and shown that when you control the cholesterol aggressively with statins, bring down the bad cholesterol, bring it down less than 70, bring the high, HDL, the good cholesterol up, the plaque which will actually shrink. And of course, smoking is an absolute no. If you're diabetic and if you're smoking, you're only accelerating your risk of heart disease and complications. So while we talked about diabetes, we talked about the microvascular complications. If we want to avoid macrovascular complications, we have to attack this entire syndrome earlier, even before you become diabetic, what we call impaired glucose pre-diabetes or metabolic syndrome, which is essentially occurs because of insulin resistance. Remember how I said the insulin doesn't work because somebody is obese and there is associated high blood pressure, cholesterol is abnormal, there are some changes in the blood. And so diet and exercise and weight control can take care of a lot of this and help early management of this and reduce the risk of heart disease. So is there a treatment that can improve all features of the metabolic syndrome at once? Is there a magic pill? The answer is yes, it is TLC, that is therapeutic lifestyle change. Yeah. So what really is therapeutic lifestyle change? It says, you know, be physically active, eat healthy, you know, have a large amount of green leafy vegetables, eat fruits, reduce your intake of saturated fat, reduce your intake of sugar, and make changes to improve your cholesterol profile so much that small changes will give you big rewards. And does treating metabolic syndrome really make a difference? You know, are there any studies to that? There is something called a diabetes prevention study, and the intervention was all about individual counseling. Individuals met with a dietitian who gave them advice on their diet, met with, were counseled regarding the need for exercise and staying compliant with exercise. So increasing the uptake of fiber and being physically active. And what did that study show? That after 4 years, you could reduce your risk of developing diabetes by 60%. So this intervention of lifestyle change, eating a better diet, exercising, making changes, which we all can do, can reduce your risk of developing diabetes by a big 60%. And if you're able to prevent diabetes, you will avoid the complications from diabetes. The ADA, the American Diabetes Association, now recommends an A1C target of less than 7. A1C is a hemoglobin is a protein which is there in the blood which carries oxygen. Glucose gets, the hemoglobin gets glycated because of glucose, and when the doctor measures this simple blood test, he or she is able to tell what the blood sugar was for the prior 3 months. So apart from the fasting and the post-lunch blood sugar which gives you the value at that time, and A1C gives the value over a period of time. So even if someone is well controlled with diabetes, the A1C level is low. So the ADA recommends that the A1C level in a diabetic patient should be kept less than 7 so that you can reduce your risk of serious complications. So how do we really prevent diabetic complications? Now again, we divide it into two. The microvascular complications, which take a long time to develop, can be prevented by aggressive screening. So that is why the endocrinologist will refer you, once you're a diabetic, to an ophthalmologist. Will recommend foot exams so you can develop neuropathy early. Will check your urine to see if microalbumin is secreted so that kidney disease is diagnosed early and treatment is instituted and you can avoid the microvascular complications. The macrovascular complications can be slightly retarded by aggressive diabetes control, but the key benefit is going to come if you're going to prevent diabetes in the first place, and the best way to do that is by lifestyle measures. Once you do develop diabetes, then we have to attack all the risk factors, which include blood pressure, which includes cholesterol, which includes lifestyle changes, avoiding of smoking, and control of blood sugar. So it's not just blood sugar, it's combination of treatment of all the risk factors. So to avoid the complications, the reason we are all here is so that we are not spending time in the hospitals. We want to prevent heart attacks, we want to prevent strokes, and we want to prevent becoming blind, going on dialysis, or suffering from nerve damage and suffering from amputations. So can you prevent heart attack? The answer to this is yes. And the question you have to ask yourself, do you really want to? And if you really want to, with lifestyle changes, with diet, exercise, and taking care of yourself, getting yourself assessed, and taking care of all the risk factors which come together is important. Thank you.